we're going to learn about assessing skin, hair, and nails. During this presentation, you'll learn several different points regarding this topic. So we're going to learn how to collect subjective data, objective data, learn about the Braden score and pressure ulcer staging, different types of skin abnormalities such as primary, secondary, and vascular lesions, and then also what those lesion configurations mean. And lastly, about patient education. So first up is subjective data collection. So with subjective data, again, that is what the client or the patient is going to report to us or how they perceive their condition. As a heads up, many diseases and disorders of the skin, hair, and the nails may be just local, or they could be caused by an underlying systemic condition. So with this, what are their current symptoms? What is their history of present illness? Like what is occurring if they're coming in with a primarily skin concern? So first up, if they have rashes, lesions, masses, skin growths, or tags, what does it look like? What's the size, color, shape? Is it raised, flat, scaly, or smooth? Has it changed over time? Dryness or oiliness, if they're coming in with those concerns. Do you notice, ask questions. Do you notice your skin feeling dry, tight, or flaky? Also, is your skin or your scalp excessively oily? And then asking about drainage or signs and symptoms of infection. Have you noticed any drainage, pus, or foul smell? Is the area red, swollen, or warm to the touch? Then you have if there's concern of an increased pigmentation or a discoloration of their skin. Asking them, have you noticed any darkening or lightening or even color patches that are uneven? And then you have sweating. So sometimes individuals may have an increase or an excessive amount of sweating or an insufficient amount of sweating. So you can ask, do you sweat excessively or very little? Have you noticed sweating at unusual times, like at night or at rest? Then next you have bruising or edema. Edema is that swelling. So do you bruise easily? Have you noticed any swelling in your legs, hands, or face? You also have acne. So have you had recent outbreaks? What triggers them? Do you utilize any special product or medication for your acne? Also asking about cicatrix, so that is scars. So do you have scars that bother you or have changed in appearance? Any kind of keloid formation? Then you have body odor. So have you noticed any change in your body odor? Do you utilize deodorants or antiseptic soaps regularly? So these are just a few questions that you can ask them to help guide that subjective data collection. Over on the side, there's a picture of a cicatrice, so that is a scar, eczema, acne, and bruising, just to give you a visual idea of what those terms look like. And in your subjective data, you also want to ask, especially if a patient comes in with any type of abnormal growth or a change in appearance of something on their skin, such as like a mole. We want to ask them if we have noticed or if they have noticed a change in pigmentation, texture. Is there a new mole? Many times if a patient has multiple or an atypical appearing mole, they are at an increased risk of having skin cancer. So what is an atypical appearing mole? What's that look like? So we utilize the ABCDEs of skin cancer or melanoma. So A is asymmetry. So one side does not look like the other side. So they're asymmetrical. B is that border. That border is very irregular. That would be concerning. C is color. Does that color look off? Is there varying tones of the color within that mole or abnormal spot? D is for diameter. So if it's greater than about 6 mm, then millimeters, we are concerned about that. And then E, different sources will say it's either elevation, so if it's risen over the skin or has a different like texture or elevation. And other resources do indicate that E is evolving, so it's changing. This spot, this mole is evolving or changing since you've noticed it. Some other concerning factors that we would want to take into consideration for an individual that has like an atypical appearing mole or spot on their skin is if that area is burning, if it's bleeding, or if there's like an itching sensation occurring. A change in an appearance or bleeding of any type of skin lesion, especially a mole, is really a cause for concern. We're thinking, is it cancerous? Is something going on? And we would want them to be evaluated by dermatology. So then next, it's also important to ask about birthmarks, tattoos, piercings, and striae. So there are certain types of birthmarks that are congenital, and you would want to know those and have that baseline in your documentation to help distinguish pre-existing marks with any new lesions or trauma during their stay. Or even if you're outpatient and you see them again in a month, do we know what is a birthmark versus a new lesion? You always, again, want to make sure you document birthmarks to prevent any misinterpretation of a bruise or an abuse-related injury. Some examples of congenital, like skin markings, that would be considered a birthmark, are your cafe au lait spots that you're going to see with like your pediatric patients, Mignoline spots, port wine stains. And then tattoos. So with tattoos, these are going to be permanent body markings that are made by inserting a pigment into the skin. So most of us know what a tattoo is. If for some reason you're seeing a patient and they just recently got a tattoo, but maybe there's a possible infection or it's not healing correctly, we want to look at is there redness, swelling, drainage? That's going to lead us to think that there may be an infection. Also, some people do have allergic reactions to that pigment in the dyes of the tattoo. And then in general, if somebody has a new tattoo and it was done with non-sterile equipment or in a non-sterile condition, then they are at risk for hepatitis and HIV. Tattoos in general can also potentially conceal lesions, bruises, or even cyanosis. So that's something that we just need to be aware of, even if they're not coming in with a tattoo-related concern. And then also, if someone does have tattoos, there is that potential for an MRI complication. So MRI is a test, and it is a magnetic field. So if they have a tattoo that maybe has some metallic ink, that could cause like burning or irritation while they're in the MRI machine. Also, just being considerate that tattoos typically have an emotional, spiritual, or a cultural importance. And so just to be aware of how we're addressing tattoos within our patients. And then next you have piercings. So piercings, we want to inspect for any infection. So if they're coming in with, pain with a new piercing, they may have some erythema, swelling, tenderness, drainage. We want to look for all those symptoms of a possible infection. Also, we want to check the healing and the placement of that piercing. So sometimes poorly healed or misplaced piercings can lead to scarring or a keloid formation. And then some people do have allergic reactions to the type of jewelry that they have in their piercing. So nickel or like a low quality metal can sometimes cause that allergic reaction. Also, many times there's a personal or a cultural significance. So we do want to approach that with respect and privacy when we're discussing piercings. And then lastly, you want to look at the safety consideration. So removing or taping certain like piercings during certain procedures or imaging, typically we just remove them completely. And then striae. So asking if they have striae, that is your linear scar-like marks from skin stretching or hormonal changes. We like to ask just to see and correlate with any history that they have. So, for instance, if someone has, had multiple pregnancies, it's going to be very common to see striae. If you have a more obese patient or someone that's weight has fluctuated, you could see striae. It also can correlate with rapid growth or Cushing's syndrome, which you'll learn more about in pathophysiology. And these are just also can indicate a possible indicator for or be a possible indicator for underlying health changes. So they may suggest like endocrine disorders, like PCOS or Cushing's syndrome, or even rapid weight gain, weight loss. With that, there's different colors and shades of your striae. So a red purple would indicate that it is new or recent stretching or hormonal influence, whereas a silvery white, those are typically going to be your older ones. They're more matured and less vascular. So in addition to visual changes in a patient's skin, we also need to ask them if they've had any discomfort with light touch or pressure, if there's been temperature changes, or they feel like their skin's colder or warmer than normal, if there's their change in perspiration, or if they've noticed an odor or maybe no odor at all. So changes in sensation or temperature, those two things may indicate a vascular or neurological issue. So for instance, an example is peripheral neuropathy. So that is typically seen in our diabetic populations or someone that has an arterial occlusive disease. So that can happen when they have a loss of sensation in their feet, or maybe a tingling, or even in their hands as well, that loss of sensation or a tingling sensation. Decreased sensation, just so that we're all aware, that can lead to a risk for developing pressure injuries. It can also lead to impaired skin integrity and skin infections. So for instance, our diabetic population, if they are experiencing peripheral neuropathy, it's really important that they do wear shoes with like a hard sole, because if they do step on, say, like a tack or step on something while they're barefoot, many times they have no idea that they just stepped on that. They don't have that pain sensation that a normal person would who doesn't have peripheral neuropathy, and then that can lead to them not caring for that wound and it becoming infected. So what about perspiration and odor? If we notice an odor off of a patient, sometimes that can just simply be because of poor hygiene. If that's so, then we do just need to provide health education and resources to get adequate hygiene. Sometimes they also may have uncontrolled body odor. That goes with excessive or insufficient perspiration. And that usually occurs due to an abnormality of the sweat glands or an endocrine concern, such as hypothyroidism or hyperthyroidism. With our older adults, we want to consider that perspiration does decrease with age. And that decrease happens because of decreased sweat gland activity as we age. So if an elderly patient comes in, they're noticing that they're not sweating as much, that's a normal finding. Also, we need to have some cultural considerations when we're thinking about these questions. Many times Asians and Native Americans have a decreased sweat production, and that typically is going to lead to mild to no body odor. Whereas whites and African Americans tend to have a stronger body odor, and they do have an increased sweat production. So now looking at specifically the hair and nail changes. So does the patient have a change in like their hair texture? Is it becoming more coarse or dry? And that can be common as somebody ages. What about the distribution? Do they notice that they're having thinning hair? Again, that is also something that is typical in your older adults, just because there is a decrease in the hair follicles. Do they notice an increase in hair? So hair in unwanted places, especially in like your female population. Sometimes they'll have extra hair growth on like their chin, down into their neck. And many times that can be due to hormonal changes, such as Cushing's disease or maybe PCOS, which is polycystic ovarian syndrome. And this can also happen with aging. So this unwanted facial hair, especially in your female, it's actually called hirsutism, Hirsutism. So there is a medical name for that. Also, maybe have they been experiencing any alopecia? That's the loss of hair. Many times it can be seen in men that are older, and that's where they'll start to lose their hair peripherally on their scalp, and then it kind of starts to move to the center, so like a receding hairline. And then you have excessive hair loss that may be, something that's sudden, and they're losing hair pretty in like good chunks. That may be because is there an infection going on, nutritional deficiencies, hormonal disorders, liver and thyroid disease, maybe possibly a drug toxicity. That's what we would be thinking if they have that excessive hair loss. If they have like patchy hair loss, that may be due to medications like chemotherapy, and possibly an infection of that scalp. Now with the nails, you may note, are they like dirty, broken, or jagged? Those type of things may indicate poor hygiene. Are they splitting, cracking, or peeling? That may indicate like weak, brittle, or layered nails. And that can be due to multiple reasons or causes. So, did they use a nail polish or nail polish remover recently and kind of peeled that back and left those nails weak? Do they live, or is it currently like a cold, dry environment? That might be dehydration of the nails, would look that weak, brittle, like cracking, splitting appearance. There may be some mechanical trauma. So do they type a lot at their job, causing the weak tips of their nails? What about, do they clean with certain products? Do they tap their nails on hard surfaces? All those type of things can be considerations when it comes to the nail trauma. Also looking at somebody who has that splitting, cracking, and peeling nail, maybe they have some nutritional deficiencies, so iron deficiency anemia, maybe like a biotin, zinc, or protein deficit. And then sometimes there are systemic or medical conditions that can cause this, such as thyroid disease, psoriasis, eczema, and then also just simply aging can cause this, or possibly fungal infections. Now, what about if they have pale or cyanotic appearing nails? Cyanotic is a like blue purpley tint that may indicate anemia or hypoxia, so a decrease in oxygenation. A yellowing discoloration, possible fungal infection or psoriasis, nail pitting, nail clubbing. Nail pinnings, typically with psoriasis, nail clubbing is it's actually a painless deformity. It's of the fingertips. The fingertips become enlarged, and then that nail bed angle increases. So the picture right above the word clubbing is actually the example. So this may indicate chronic hypoxia or systemic diseases. So usually I think like a COPD patient, someone with pulmonary fibrosis, sometimes cirrhosis, malabsorption syndromes, but typically your respiratory, COPD, pulmonary fibrosis, cystic fibrosis. You can see thickening nails that typically will happen in individuals' toenails. That's due to a decrease in circulation. And then you can also see these longitudinal ridging, and that's seen in commonly in our elderly and some young individuals as well, but there's really no etiology or backing of why that's occurring. So when taking their personal health history, we do want to make sure that we ask, did they have severe sunburns as a child? Those severe sunburns can increase their risk factor for skin cancer in the future. Do they have previous skin conditions? Do they have known eczema or psoriasis? Hospitalizations. Many times, hospitalizations can increase their risk for hospital-acquired infections such as MRSA. Major surgery or certain illnesses can change, and cause temporary cessation of hair and nail growth. So that stop of hair and nail growth that can lead to those abnormal findings. What about allergic skin reactions? Do they have any type of allergies or allergens that can precipitate as different skin eruptions or like hives? What about recent illnesses? If they have like a current rash or a lesion, is that possibly related to an illness, whether it's viral or bacterial? Also, in our female population, are they pregnant? Many times with pregnancy, you can have those skin and hair conditions change due to that hormonal imbalance. Do they have a history or have they had self-harm or injury that you may be able to see like cicatrix uh, from that scarring? Also, like anxiety and depression in and of themselves is, just so you guys are aware, is not typically associated with skin issues. It's just that when they have that depression, anxiety, that leads to potentially self-harm, we would just see that through like the scarring. So we may see like a cut, burn, certain scratching that can cause that. And then when you're looking at family history, were there recent illnesses or skin issues within the family? Many times, certain viruses can be very highly contagious, thinking of like measles, chickenpox, acne, and atopic dermatitis. Those tend to be familial and they run in the family. And then some allergens as well can be familial as well. Do they have a history of skin cancer? There is a genetic component with skin cancer, so we do want to ask that. And then we have keloids. The keloids are more common in individuals of color, so African American, Asian, and in persons with a family history. So they commonly will form between like the age of 10 and 30. And this can be due to like ear piercing, body piercing, like a surgical scarring, or potentially other skin wounds, and it causes this like keloid formation at that area. And then we always want to ask about lifestyle practices when we're obtaining our subjective data. So, do they sunbathe? Do they utilize sunscreen? And sunbathing also is whether they're tanning in a tanning bed or in the natural sun. We do need to know that. If they are tanning, that's going to increase that risk of skin cancer and potentially even hair damage as well. Then the sunblock or sunscreen. Are they utilizing it? What level SPF are they doing? Are they doing skin self exams? If they are, how are they doing it? How are they inspecting their skin? So that's a big education point as well, which we'll talk about here shortly. And then do they have a job or, are they retired and they have long periods of sitting or lying down? So thinking of like our older patients, if they are disabled or immobile, they are going to be spending those long periods of time in one position. And when they are in one position for a long period of time, that's going to increase that risk of impaired skin integrity that can lead to some skin issues. What about exposures to extreme temperatures? So the blood supply to the skin can change with temperature. So if it's really cold, do you notice any like frostbite, discoloration in the fingers, the toes? If it is really warm out and they're in like the sun, certain types of burns. What about piercings? Do they have a history of piercings when they got that piercing or even tattoo? Did they have an allergic reaction? Many times people do have allergic reactions to certain metals with a piercing. Tattoos, typically it's going to be that risk of infection if they're not getting it sterilely, and then that risk for like certain diseases such as like hepatitis C. And then we always want to ask about food consumption. Do they have a balanced diet? Are they adequately hydrated? And that can help when we're assessing that skin. So, are they really dry, cracky skin? Well, then maybe they need to be hydrated. So, we need to ask about that food consumption. Also, alcohol consumption, smoking history, that can be connected with psoriasis. And then skin problems. do these skin problems and issues affect your normal activities? So sometimes if you have, say, like poison oak, poison ivy, and you're very active outside, that may limit the certain activities like hiking, camping, gardening, whatever you're doing outside. It may limit those activities while you have that, poison oak or poison ivy. Also, stress, those can cause or even exacerbate certain skin abnormalities. So let's talk about objective data collection with skin, hair, and nails. So objective collection, so how do we really prepare for a skin, hair, and nail assessment? So first we want that client to remove any clothing, jewelry, we'll get them in a gown. Ideally, if they have nail polish or artificial nails, that those are removed. Even on their nails or on their toenails. If they have a wig, toupee, any type of hair piece, we do ask that that is removed so we can get a good look at the scalp. If they have any pins or clips as well, just to make sure that, those are off. The client, like I said, is to wear a gown. We really want to make sure that they are comfortable, that we have privacy, that we inform them that anything that they share with us is just between them, us, and their healthcare team. Those typical professional introduction key points that you'll learn in lab. You also want to utilize natural light as much as possible. So a question here is, what cardinal techniques will you use to assess skin, hair, and nails? Select all that apply. So you can pause this now, and then you can unpause it when you have your options. So the correct answer is going to be inspection, which is A, and B, palpation. So during a skin, hair, nail assessment, we will just be inspecting and palpating. No percussion or auscultation will be utilized. So then another question, should you wear gloves when assessing skin, hair, and nails? The answer is yes. You should be wearing gloves during this time. You don't know which may be contagious or not contagious or easily spread. And so really anytime that you have anything that's abnormal and you're going to be especially palpating it, I would definitely be wearing gloves. So objective data collection on our inspection. So for the skin, you would want to look at like the overall color. So what's the overall color, the undertones, is it uniform throughout the body? Many times I will say their color is consistent with their ethnicity. You want to look at the exposed versus unexposed area. So really making sure you're doing a complete assessment. You're looking for any darkened, pale, yellowish, or bluish hues. If it's pale, it could be that they're maybe anemic or have decreased circulation. They may have cyanosis, which would indicate hypoxia, jaundice, when they have that yellowing tint to them, that can be an indicator for liver dysfunction. Do they have hyper or hypopigmentation? Hyperpigmentation, many times, if they have like the dark spots, that can be related to an endocrine disorder. And then if they have hypopigmentation, that can be maybe scarring, vitiligo, different types of diseases and conditions. So then you go down to perspiration. Is there like an odor with it as well? So we want to assess the moisture level and odor. Normal skin, what you typically will see will be warm and dry with maybe mild perspiration. If they have excessive sweating, maybe they're having a fever, anxiety, hyperthyroidism. Whereas if you have a lack of perspiration, are they dehydrated? Is there an autonomic dysfunction? But then also correlating it back to what is their age and ethnicity, because those can cause those changes. If there's a strong odor, that can indicate poor hygiene, infection, or a metabolic disorder. Then you go to rashes. So we're looking for any rashes, identifying location, pattern, and distribution. Is it localized, generalized? Is it sporadic? Is it symmetrical on one side compared to the other of the body? You want to know any color, shape, and presence of scaling or any type of crust. And so that would be important. And we'll kind of go into like more specific terms for different like lesions and rashes here in a little bit. So for lesions or tears, so we want to inspect for that, inspecting for is there a break in skin integrity, abrasions, open wounds. We want to assess the surrounding tissues. Is there a pressure injury or maybe skin tears? That can indicate impaired mobility or fragile skin. And then you've got ulcers. Those would indicate a potential circulatory compromise or infection. Then you have lumps, bumps, masses. Any type of lump, bump, or mass, you want to note the size, shape, color, location, mobility of it. You want to distinguish between cysts, nodule, and lymphomas, which that, again, we'll talk about a little bit more here in a few slides. So this may indicate that it's a benign cyst, malignant lesions. So we'll really want to make sure that we follow those ABCDs. Then you have scars or cicatrix. So you want to identify the presence, the size, appearance. You can note the texture and pigmentation of those. Also, what about edema? Is there any swelling that would, indicate a concern? Although sometimes swelling will look like very taut, shiny skin, and you want to compare from one side of the body to the other. Localized edema is going to be more inflammation or infection is what we're going to think is going on. But a generalized edema kind of throughout the body, we're going to think, is there a cardiac issue? Is there an issue with renal function or maybe possibly liver failure? Bruises, also what we call ecchymosis. We need to observe the color, size, and stage of that healing. So you might see different coloring. Multiple bruises in different stages may indicate a trauma or abuse. And then excessive bruising, we need to look at coag therapy. Are they on any type of medication that would cause them to bruise easier? And then you have burns. So burns, you want to assess location, depth, color, and pattern. And you also want to look for, is that burn, is it pretty pattern? That would indicate maybe a non-accidental injury, where extensive burns or unpatterned, what's going on. With extensive burns, you're going to have that risk for infection, fluid loss, or hypothermia. You also have skin growths or skin tags, so we really want to make sure that we're assessing all of those moles, warts, skin tags, note the color, border of it, and surface changes. Again, looking for anything that would be abnormal, and you would follow that ABCDE rule. You will see with skin tags, they are fairly benign, especially as someone ages or if they do have obesity. And then last, you want to look at infection and drainage. If there is any type of drainage, noting what that looks like, if there's a foul odor with it, do they have swelling and warmth or redness around the area that is draining. This all can indicate different bacterial, fungal, or viral infections. So then with your nails, you want to look at overall, that's going to show like overall hygiene. So you want to assess the cleanliness of the nails and the surrounding skin. Is there dirt, debris, fungal buildup under the nails? Many times, if somebody does have poor nail hygiene, it may indicate some self-care deficits or possibly like an occupational exposure if they're getting their hands dirty. So then you want to look at color. Normal coloring of the nails will be a pink. And then once we get to palpation, we'll talk about capillary refill. Any abnormal findings, paler, cyanosis, yellowing, brown or black streaks, those can indicate a concern. You want to look at the length of the nails, looking for any spots. So any white spots or pigmented parts. White spots are typically from like a minor trauma, but persistent discoloration can signal maybe a systemic illness or a medication side effect. Is there any indentations in the nail? Is there splitting, cracking, peeling? We kind of talked about that earlier, what that may indicate. Pitting, clubbing, those type of things are what you're going to be inspecting for. Then when we move to the hair, so looking at the color, observe that natural hair color and any changes. Are they graying? Is it an unusual pigmentation? Changes in the natural hair color could potentially indicate nutritional deficiencies, of course, aging, or maybe even some systemic diseases as well. Is there any alopecia? What's that distribution look like? Is there dandruff? Dandruff is also called seborrheic dermatitis. So, is there flaking or scaling on the skin that could just be associated with dryness, any fungal infection, some skin conditions? Are there lesions on the scalp, reddened areas, and then also looking for parasites, so lice, nits, or other parasites that are present, and they may have like itching or signs of like a secondary infection with that. So what are some skin color terminologies? So we've kind of talked about a few of these through previous slides. So you have cyanosis. That is going to be that bluish purple discoloration on the skin or mucous membranes. It can indicate that hypoxia or poor perfusion, potentially cardiovascular or pulmonary issues. We want to look for central and peripheral cyanosis. Central is going to be more your tongue, lips. Peripheral is your finger and toes. Then you have jaundice. Jaundice is that yellowing of the skin, the sclera around the eyes, and mucous membranes. That typically indicates an elevated bilirubin, and then that's due to liver disease, hemolysis, or maybe a bile duct obstruction. Then you want to look at paler. That is pale or ashen colored skin, may indicate anemia, blood loss, decreased perfusion. And then rubor is redness. It's red or flushed skin, can be due to inflammation, fever, allergic reaction, or maybe even dependent extremities and peripheral vascular disease. You have mottling, that is a patchy, irregular skin discoloration, often associated with poor circulation, shock, or chronic illness. And then you have acanthosis nigricans, and that is a dark, thickening, velvety patch. It's typically within like body folds, so the neck, underneath the armpit, in like the axilla, and in the groin. It's typically associated with insulin resistance, obesity, or endocrine disorders. And then you've got albinism, and that is a congenital absence of melanin pigmentation. So the skin's going to appear very pale. There's an increased risk for sunburn and sunskin or skin cancers with this. And then erythema, that is redness due to increased blood flow, common in infections, inflammation, allergic reactions, and trauma. So with palpation, you want to, for your skin, you want to check for texture, thickness of the skin. What about that moisture? Is there any dryness, oiliness? What about edema? Edema is going to be that presence of swelling within the body. We do grade this, but you will learn that when we talk about CVS, PVS in a few weeks, and that can indicate fluid overload, heart failure, or venous insufficiencies. What about lumps, bumps, masses? We want to palpate for those. Is there any pain or tenderness when we are palpating them for the patient? Next is temperature. That's going to be a big one that we want to assess for, is their skin warm? Is it cool, hot, or cold? And we always want to compare bilaterally. Those abnormals can indicate infection, inflammation, or poor perfusion. And how we will palpate for temperature is we will actually utilize the dorsal side of our hand to assess that. And again, we do that bilaterally going down. And then you want to look at that skin turgor. So that's going to test that hydration status. It's looking at the elasticity of the skin. So we will teach you to pinch up by the individual's clavicle, but you can also do it on like the forearm or the sternum, but you'll pinch up and then quickly release. We want to see a rapid return. That indicates normal hydration, whereas if it slowly returns back to normal, the patient may be dehydrated or they may have some edema. And then with the nails, we want to palpate for their texture. Are they smooth? Are they flexible? Are they like kind of thick feeling? Are they brittle? What is that feeling? And then we also want to check the and palpate for a capillary refill. This is where we press on the nail bed until it blanches and then release, and the color should return within 2 seconds or less. If there is a delay in this, it may be due to poor perfusion or cardiovascular compromise. Also for capillary refill, if somebody has nail polish, whether it's on their toes or their fingers, then what you will do is you will touch at the most like distal side of their finger and press down and look for it there. But ideally, they're not wearing any nail polish when we're doing this assessment. And then for hair, you want to feel for the texture. Is it fine, coarse, brittle, soft? Again, those type of changes could be due to nutritional deficiencies, thyroid disorder, hormonal imbalance. You want to check for the moisture. Is it dry? Is it oily? What about distribution and possibly even shedding? So we want to make sure that we are looking for any hair loss, patchy hair loss, and we talked about that earlier. And then you want to look at the overall scalp health and palpate for that. Is there any shedding? Palpating for like lumps, bumps, lesions on that scalp, and then overall cleanliness. Next, we have the Braden scale and pressure ulcer staging. So with the Braden scale, this is going to be utilized to predict the risk for pressure ulcer development to guide prevention strategies. It's going to help prioritize interventions for those high-risk patients of high risk for a pressure ulcer. So how do we utilize this? So we have to look at each subscale or subcategory, and then we will assess. So higher total scores indicate a lower risk, whereas the lower the score is, the higher the risk they're at. And we want to reassess this Braden scale fairly regularly. We want to do it daily or with any change in condition. And of course, we want to follow the hospital protocol for it and policy. So with this, we will look at, so you have sensory perception, so the ability to respond meaningfully to pressure-related discomfort. So is it completely limited, very limited, slightly limited, or no impairment? And you guys can read through those. Then you want to look at moisture. What is the degree to which the skin is exposed to moisture? Is the skin constantly moist, very moist, occasionally moist, or rarely moist? And then activity. What's the degree of physical activity? Are they on bed rest, or it's called bed fast on here, chair fast, walks occasionally or walks frequently? Mobility is their ability to change and control body position. So are they completely immobile, very limited, slightly limited, no limitation? And then nutrition. What does that usual food intake look like? What's that usual food intake pattern? Is it very poor, probably inadequate, or excellent? And then you look at their friction and shear. This is your only one that has the 3 score, just 1, 2, and 3. Is there a problem, a potential problem, or no apparent problem? So we want to look and assess this at least, like I said, once a shift. Ideally, if there's any changes, you would want to as well, but obviously looking at your policies and procedures for your healthcare facility that you're working at. So with that, what are some nursing interventions for like those high-risk patients? So what would determine a high-risk patient is going to be if they score between a 10 and a 12. If they score less than a 9, they're very high risk. And then if they score a 13 to 14, it's moderate, and then at risk is 15 to 18. So for this, if they are at that high risk, we want to reposition every 2 hours. We want to utilize pressure relieving devices, so special mattresses or cushions. We want to keep that skin clean and dry, manage any moisture, and then ensure that they are getting adequate nutrition and hydration. And then we want to monitor that skin very closely, especially over those bony prominences. So let's get into pressure staging, pressure ulcer staging. So stage 1 and stage 2. Stage 1 is when the skin is intact with non-blanchable redness over that bony prominence. So the skin may be red, it may feel warm, it's going to probably be firm or potentially soft compared to that surrounding tissue. It's just going to feel different. The patient may report like a pain or an itching sensation at the site. Color change may be difficult to see in your darkly pigmented skin. So you're really going to want to make sure you're looking at that skin temperature, texture, and firmness changes. So as a nurse for someone that has a stage 1 pressure ulcer, we want to make sure that we are relieving pressure on that affected area. We can utilize pressure relieving devices like cushions, mattresses, like certain mattresses. We do have air mattresses as well to help with that pressure. We want to keep that skin clean, dry, and maintain hydration in that patient. And then we want to monitor skin frequently for changes. And then we do want to provide the education for turning and repositioning. So then stage 2 is going to have more of a partial loss of that skin and dermis. That's going to be your biggest change. Now the skin, that dermis layer, is going to be impacted. There's going to be a potential open ulcer. That wound bed is going to look very pink and red. It's just very irritated, but there's no sloughing in here. And these are 2 good pictures to compare. So then you have stage 3 pressure ulcers. So this is when you have a full thickness skin loss involving the epidermis and the dermis, extending into some subcutaneous tissue. With this, you will not see any bone, tendon, or muscle. That should not be exposed. That would not be a stage 3. So it's going to look kind of like a deep crater-like ulcer, and you can see that in the picture in here as well. Subcutaneous fat may be visible, but that's not, it's not always visible. But as I said before, bone, tendon, muscle are not going to be visible. You may have some undermining or tunneling. This can be very painful and prone to infection for that patient. As a nurse, we want to relieve pressure immediately. We want to clean that area as ordered by the physician. We want to apply any appropriate dressings that are ordered. So there's like foam, hydrocolloid, or anything that's prescribed to help with that. And then you really want to make sure you're monitoring for infection. So what's infection going to look like? It may have an odor. There may be some drainage. What's that drainage look like? Increased redness and warmth. We also want to consider different nutritional support options to help promote that healing. And then we always want to document the size, the depth, and the presence of any tunneling or undermining. So documentation is going to be very important with your ulcers or any skin changes. And then you have a stage 4. So this is when you have full thickness skin and tissue loss with exposure of the bone, tendon, or muscle. It doesn't have to be all 3, it's just one of them. So in your assessment findings, you're going to see like a deep wound, you're going to see visible bone, tendon, or muscle. Oftentimes there's very extensive tissue damage and undermining or sinus tracts. So that's like really far tracking and tunneling throughout underneath the skin. They do have a high risk of osteomyelitis or systemic infections. So as a nurse, we again want to relieve pressure immediately and very frequently. We want to consider like consulting a wound care specialist. Honestly, here at OSF, we get them involved as quick as possible. We have an amazing wound care team. You want to utilize special dressings that are ordered by the physician, monitor for those infections, monitor for sepsis, provide adequate nutritional hydration and pain management. And then again, we want to look at that wound size, depth, and tissue involvement carefully. So then you have an unstageable pressure ulcer. So this is when you have full thickness skin and tissue loss, but the extent of tissue damage cannot be determined. Why can it not be determined? Because it is covered by slough or eschar. It's like this yellow tan, possibly gray, green, sometimes even a browny black necrotic tissue. So that is covering the bed of the wound, so we don't know how to stage it. The true depth of the wound is really unknown because of this. Really, we will have to get rid of that necrotic tissue to expose the base to see what stage we can stage it at. So assessment findings, with this, the wound is completely covered with that slough or eschar. There may be underlying tissue damage. You may see muscle, bone, tendon, but typically we're not going to see it. They may have it, but we will not see it until we get rid of that slough or eschar. So we're not going to be able to measure that depth due to that eschar or slough, and so we would have to get that debriefed. So for us as a nurse, we do not want to remove any stable dry eschar on the heels. That's going to provide that natural cover. We want to make sure that we maintain pressure relief and frequent repositioning. We want to clean the surrounding skin and maintain a moist wound environment. You don't want that to kind of like heal off. We want to make sure that it's moist to help bring hydration to that area to help pull the skin back and get it back to normal. You want to monitor for infection, redness, drainage, color, or systemic signs. And then we definitely want to collaborate with wound care, surgical specialists for debridement or advanced management. Us as nurses at the bedside, we will be staging ulcers. But of course, we have a wonderful wound care team that will be there to double check things and provide recommendations. And so we really do heavily rely on them. But unfortunately, with the increased amount of pressure ulcers that we're seeing, we as nurses, we need to be able to differentiate a stage 1, 2, 3, 4, and unstable. And again, you want to always document, while we can't maybe document the depth of the wound, you want to look at the appearance, document the appearance, color of the tissue, covering the ulcer, the size, and any drainage that you know. So then skin abnormalities, we're going to look at the primary, secondary, and vascular lesions. So primary lesions, those are going to arise from normal skin due to irritation or disease. Secondary lesions are going to arise from your primary lesions or from a behavior or exposure. Then you have vascular lesions. This is associated with bleeding, aging, circulatory conditions, diabetes, pregnancy, or hepatic disease. This is all vascular related. Okay, so with primary lesions, you've got several different ones. So you've got a macule that is going to be a small, flat, non-palpable skin color change. Typically, macules are less than 1 centimeter and have a circumscribed border. Whereas a patch, you can kind of compare the two. Patch is going to be very similar to a macule, but patches are greater than 1 centimeter and have an irregular border. That's the difference between those two. Examples of a macule or patch are freckles, flat moles, petechiae, will look like a macule, rubella, port wine stains, ecchymosis. Then you have a papule. That is an elevated, palpable, solid mass. They're typically less than 1/2 centimeter, and they do have a circumscribed border. A plaque is going to be very similar to a papule, but they are greater than 1/2 centimeter. Then examples of those, papule typically like warts, and then plaque is going to be like your psoriasis. Nodules are going to be an elevated, solid, palpable mass that extends deeper into the tissue than a papule. So it's going to go deeper into the dermis than that papule. Nodes are typically 1/2 to 2 centimeters, and they are circumscribed. These are going to be like keloids, lymphoma, possibly a poorly absorbed injection site. Then you have a tumor. This is going to be similar to a nodule, so elevated, solid, palpable mass that extends deeper into the dermis than the papule, but it's going to be greater than 1 to 2 centimeters. So tumors are going to be larger than a nodule. So greater than 1 to 2 centimeters, and they do not have sharp borders. So it can be irregular. That's lymphoma or sarcoma. Then you have a vesicle. So vesicles are going to be circumscribed, elevated, palpable masses, but they're going to contain fluid, or serous fluid. Vesicles are typically less than 1/2 centimeter. So think of like poison ivy, second-degree burns, varicella, herpes simplex zoster. Then you have a bulla. A bulla is similar to a vesicle, but they are greater than 1/2 centimeter. So this is like contact dermatitis, poison ivy. If it is larger than that 1/2 centimeter, then it would be a bulla, and potentially impetigo. Then you have a pustule. This is a vesicle or a bulla that has pus filled. So it's not just a serous fluid, it is going to be a pus filled. So this, we're going to think impetigo, acne as examples. Then you have a cyst. So this is an encapsulated fluid filled or a semi-solid mass located in the subcutaneous tissue or dermis. So these we have some sebaceous cyst, epidermoid cyst. Those are just some examples. A wheal is going to be an elevated mass with transparent borders that is often irregular and that color and size may vary. So this is caused by movement of serous fluid into the dermis. It does not contain free fluid cavity. That would be a vesicle. So for instance, with a wheal, think any allergy testing that somebody does, they typically do it on the back. There will be these little wheals like elevated underneath the skin. Then you have TB testing. You probably got a TB test before nursing school where they put it underneath your skin in your forearm. Hives or your urticaria is an example of a wheal, or even an insect bite. So then you have secondary lesions. So secondary lesions, again, this is usually due to like a trauma, irritation, or from a primary lesion. So you have excoriation. That is going to be more of a mechanical trauma. So you'll see it if you like scratch, if you pick, or you're rubbing at your skin. And so that is what excoriation would be. And erosion is a loss of the superficial epidermis that does not extend into the dermis. And so it's kind of like going to be a depressed, moist area. This is if like a vesicle, again, a primary lesion, were to rupture. Sometimes scratch marks will be an erosion as well, or the ipthostos ulcer, or aka a canker sore. Then you have a fissure. A fissure is going to be a linear crack in the skin. It may extend into the dermis, and typically it's going to be painful. So thinking of like athlete's foot, chapped hands, chapped lips, that would be a fissure. Then you have cicatrix. That is going to be a scar. So that is skin that is marked left. There's a skin mark that is left after a healing wound or a lesion. It is going to look, why it appears the way that it does is because it's that replacement of connective tissue at that injury site or that injured tissue. Younger or newer cicatrix is going to look red, purple. And then more mature cicatrix is going to be white or glistening. Ulcers, so that's going to be considered skin loss extending into the epidermis with potentially necrotic tissue loss. There may be bleeding or scarring. And again, this is an example of like a pressure ulcer would be an example of an ulcer, pressure injury. Then you have a scale. A scale is going to be that flaky skin. It can be either thick or thin. Typically, you'll see that with individuals with psoriasis, dandruff, eczema. And then you have your vascular lesions. So you have ecchymosis. So this is round or irregular macular lesion. It's larger than petechial lesion, which we'll get down to. The color is going to vary and change. You may have black, yellow, and green hues. Typically, this can be due to maybe a coagulation disorder or a medication that they're on, or a trauma that occurred. So they ran into something, like they hit the side of the table, and then that caused that ecchymosis or bruising. A hematoma, that's going to be a localized collection of blood. It's going to create a more elevated appearing ecchymosis, and that's typically due to trauma. Purpura, that is going to be a larger petechiae, and it's non-blanchable, typically seen with vasculitis or clotting disorders. Petechiae, those are going to be those round red or purple macules that are about a 1 to 2 millimeter in size, typically due to or secondary to blood extravasation and associated with bleeding tendencies or an emboli to the skin. Then you have a strawberry or cherry angioma. That is going to be a papular and round. It's going to be red or purple. And it's typically like lesions that are going to be found on the trunk or extremities, and it may blanch with pressure. This can be a very normal age-related skin alteration, and it's usually not overly significant clinically. Then you have a spider angioma. That is going to be a red arterial lesion with a central body and radiating branches. Usually noted on the face, neck, arms, or trunk. Going to be very rare below the waist. Typically seen with liver disease, pregnancy, or a vitamin B, as in boy, deficiency. Then you have telangiectasia. That is also called spider veins. So they are a bluish or red lesion with varying shape. It is like spider-like, pretty linear. It's found on legs and possibly the anterior chest. It does not blanch upon applied pressure. This is typically related due to secondary to superficial dilation of venous vessels and capillaries. And it can be associated with an increased venous pressure, such as like varicosities. Lesion configuration, you have several ways that those lesions can be configured. So you have linear, which is a straight line. Typically that's going to be from like a scratch, cicatrix. Then you have annular. So that's a circular lesion. So if you think of Tinea corporis, that is ringworm. And that's going to look like a circle. Then you have cluster. That's going to be where they are grouped together. You'll see that commonly with herpes simplex. You may have discrete, where it's individual distinct lesions. And then you have nummular. That is going to be a more coin-shaped, and that may be like eczema. And then you have confluent. So that is small lesions run together to back bigger, larger lesions. And so they're kind of all over in appearance, and that can be that Tinea versicolor. So nursing considerations and patient education. We want to also make sure that we educate our patients on how to do a skin self-exam. So we want them to do this at least once a month is the recommendation. It's best done after a shower or bath when that skin is clean, and then completing it in a well-lit area. They want to utilize a full-length mirror and a hand mirror to really make sure that they visualize all the areas, including like their back and their scalp, those hard to see areas with just a full-length mirror. We do encourage that they ask for help from a partner or family member if they feel comfortable to visualize those hard to see areas. So we want to ensure that they are also checking underneath their breasts, their arm area, their underarm areas, their palms of their hands, in between any of their fingers and toes, the buttocks, genitalia area, back of the neck, the scalp, and behind those ears. So again, those are some hard to see places, and that's why we need to have them utilize a hand mirror or ask a partner or family member to assist them. So then what should we be looking for? Remember back a few slides, we talked about the A, B, C, D, E of the skin assessment. So is the mole or a skin lesion that they're looking at, is it is it asymmetrical? Is that border irregular, ragged, blurred? What does that look like? What about the color? Is there uneven color with like shades of brown, black, maybe some red, white, or blue in there? What about diameter? So that's the D of the ABCDE. If it's greater than 6 millimeters, so really thinking of like the size of a pencil eraser, then we're going to start to get concerned. And then E is for evolving. Is there a change or elevation? Is it elevated? What does it palpate, feel like? And then is it evolving? Are there changes in the size, shape, color, elevation? Do they have any new symptoms like bleeding, itching, or maybe crusting over it? And those would be concerning. So with education that we can provide our patient regarding skincare and prevention, we want to make sure that we are educating on daily skin hygiene, on hydration, making sure that they're drinking plenty of water and fluids. For sun protection, what SPF are they utilizing? If they're utilizing anything below a 30, we do recommend that they utilize an SPF 30 or greater, making sure that they are getting it behind their ears, on their ears, and between their hands in all the places. We want to educate on avoiding tanning beds or excessive sun exposure. If they are going to be out in the sun, say maybe they're a landscaper or somebody who works outside, making sure they're utilizing protective clothing like sun hats, those long sleeves, long pants, just to help protect that skin from that unnecessary sun exposure. Then with hair care, we want to educate on hair hygiene. Educating that hair loss sometimes can be due to stress, hormones, nutrition, so watching their food intake and certain medications. We want to make sure that they know to call the provider if they have any sudden or patchy hair loss, if they have scalp irritation, sores, or persistent dandruff, or if they're noticing that unnormal or unusual excessive hair growth on unwanted areas. With nail care, we want to make sure that they do know nail hygiene. We want to encourage them to avoid biting their nails or cutting at their cuticles. And like for toenails especially, making sure that they cut straight across and they don't cut in like a circular shape or like a half oval, because that actually can increase their risk of infection. Making sure that they know to call a provider if they have any discoloration, thickening, or separation of the nail, if they have any signs of infection, or if there's nail changes along with any systemic symptoms. As always, if you have any questions regarding this content, please reach out.